I also, as Michael, have a deep respect for our next speaker, Charlie Coffey from Vanderbilt University. I never had a chance to work personally with him, but my interactions with him have been great. I know anyone who has had the luck to work with Dr. Coffey has gone away a better person. So I'm looking forward to his remarks.
Thank you very kindly. I'm at that awkward stage in life where I can't see up close and I can't see far away. So one of these says advanced, doesn't it? The top, okay. Also, I can't see the screen here and I can't see the screen there, so if you don't mind, I'm going to step down here, get a little closer to you. Just stifling my creativity, I suppose. Okay, as some of you know about the Vanderbilt program, we have had this DMP idea burr under our saddle now for a couple of years. And when I was asked to speak today, the topic was the future of education in the United States for medical physicists. And I quite frankly told the person who invited me, I don't think I know anymore. But let me tell you what I do know, and that is there's a model called the DMP, and it's working. So I could get down off the stage now, and that would have been my presentation. It can be done. My last slide ends with it can be done. So let me tell you up front, it can be done. So in the next 15 or 20 minutes, the goal of what I want to tell you is how Vanderbilt has put together this thing called a DMP, and the fact that it is possible, and I think it's a model that could work for medical physics profession and education in the future. We'll talk briefly about the history of the Vanderbilt program, the current status, number of students, curriculum, etc. Some lessons learned to date, some future plans, and perhaps some updates from other institutions who are considering the move to a DMP. Faculty approved the concept. We as a medical physics faculty, about 2007, 2008, we thought it was a workable solution. So as a group, we elected to put it forward. At that time, we had to get the School of Medicine approval. We're in the School of Medicine. And eventually, Vanderbilt University approval. So a couple of academic approval processes. Now, in asterisks, you see that we do not have the State of Tennessee Council of Higher Education. Vanderbilt is a private institution, and hence the programs that it elects to approve do not need to have state approval. So if you are a state institution and a graduate program director considering a DMP program, added to the burden of faculty approval and university approval is going to be your individual state's approval. Okay, so we didn't have that process, so as a result, we probably knocked off about maybe 6 months to perhaps 18 months in the process without having to do that. So in around April or May of 2009, the Board of Trust approved our program, so we became official. Well, we had secretly been running a program for a number of years, so as a result, on basically July the 1st, we moved a bunch of students who were in the second year of our master's program into the DMP program in year 3. Instantly, we had a DMP class. The first year master's students elected to move into that. So immediately we had a year 3 and a year 2 DMP class. And we recruited that year. So in 2009, we had 3 3-year students, 4 year 2 students, and 4 year 1 students. So from nothing, we suddenly had a total of 11 students. We applied for CAMPEP accreditation and was approved for that in July of 2010, so just about a year ago. How did that CAMPEP accreditation come about? Well, it was new, so CAMPEP didn't have a model, so I said, let's model it after what we know. Vanderbilt did have a master's CAMPEP approved graduate program. At the time, Vanderbilt had a single CAMPEP approved residency slot. So I said, if we can do the education part right for master's, let's just roll that into our DMP. And if we have a CAMPEP accredited residency in therapy, let's just roll that into our DMP, and we've got 2/3 of the problem solved. The piece that we didn't have solved was our diagnostic track. We did not have a CAMPEP accredited diagnostic residency. So just as Mike Mills described to you, you don't have to reinvent the wheel. So we took what others had done and basically submitted their programs and said, hey, here's our model now for a Vanderbilt MS, for a Vanderbilt residency in therapy, and for the example diagnostic residency. So we submitted a self-study, and after the self-study, we did get a site visit, and 2 different groups came in that one site visit. We had the graduate education reviewers, and we had the residency reviewers. So they were reviewing 3 programs, basically. The graduate medical education program, and a diagnostic residency, and a therapy residency. They did accredit the program. If you will carefully note on the APM website or a CAMPEP website, it is not a DMP program. So it's called a combined program. So again, there is nothing according official to the AAPM of a DMP. So we use the nomenclature, but it's not an official group yet. So not an entity. So CAMPEP said, okay, if you don't have an entity, we will call it a combined program. So Vanderbilt is the first to have a combined program. What that means is that we have a CAMPEP accredited graduate education program and a CAMPEP accredited residency program. Now, Vanderbilt will graduate in a couple of months its first DMP student. Okay? That diploma will say DMP. Okay? So CAMPEP says we're a combined program. The Vanderbilt diploma will say a doctorate in medical physics. Current status. So we have 3 4-year students, 4th-year students, 4 3rd-year students, 4 2-year students or 2nd-year students, and 5 year 1 students. For the first time last year, we were able to recruit not only the therapy side, but also a diagnostic. So we're very proud of the fact that finally last year we have our first diagnostic person in that diagnostic track. As I mentioned, just a month from now, we will graduate those first 3 gentlemen as the first DMP graduates from Vanderbilt University. The recruitment efforts for this fall have been similar. So we have pretty much elected that our program can handle 4 therapy DMPs per year and 1 diagnostic. So our goal this year was exactly that, to recruit for this fall 4 additional therapy DMPs and 1 diagnostic DMP. So we did that. We have our 5, and we elected to bring on 2 master's folks. One of those will get a master's degree in therapy and will leave the university. The second of those will get a degree in diagnostic track and leave the university. They understand up front that there is no guarantee for them to get a residency. There's no guarantee for them to find a job. Fortunately, we can tell them that we have had residents who have left at the master's level who are finding residency slots. But we do understand, they do understand that there's no umbrella for them should they not find a position in a residency or a job. I will make a point later on that becomes an ethical issue for program directors. How can we continue to bring on MS students if we don't have a guaranteed residency for them? So just as Mike pointed out, that's a real liability for me as a program director. So it could be in the very near future, as of fall of 2012, that Vanderbilt may discontinue our master's program. The curriculum. What does a DMP program look like? Well, we didn't have a model. So that's good news, bad news. There's no one to gain experience from. That's the tough news. The good news is Well, if you're going to set a standard, now's a good time to do that. Some of you were there when I spoke a couple of times at the AAPM, and this was not a pleasant subject. Some of you were not thrilled with the idea. I took your criticisms to heart. I tried to make this a model program where you as a society, you as a profession, would be proud of what we were putting together. So the basic premise was this. The DMP program that I wanted to help develop or help bring forward was not simply a master's degree plus a 2-year residency. Because many of you have that and you can't get a DMP because you don't need a residency now. So it had to be something different. So this is what Vanderbilt said to make it different. So instead of the 32 hours to get a master's at Vanderbilt, okay, 32 didactic hours and 6 hours of what I call practicum. So imagine practicum is working at QA, doing treatment planning, doing brachytherapy, equivalent of about 2 to 3 to 4 full-time months of work. Okay, so 32 didactic hours plus those maybe perhaps another 300, 400 hours in clinical rotations. So that is the picture of our MS Medical Physics program, about a 22-month program. Well, that's 32 hours. I said that's not enough. If we're going to be a professional doctorate, then other programs that are out there, so pharmacy, for example, you can get your PharmD degree. Well, it's not a master's degree plus going to a pharmacy somewhere and getting 2 years of rotational training. That's not what a PharmD is. It's more. And it's more in the classroom. So I said, let's make it more in the classroom. So we upped the ante from 32 hours to 50 hours of semester credit. So that's the didactic work. Some of you said, well, Charlie, what you need to do is put some research in there. Yes, but it can't be a research project. It can't be a MS research project. It can't be a PhD project. There's not enough time to do that in a 4-year program. But yes, I heard your comments. I tried to make that happen. So we've put in a research project worth about 6 credit hours. So that's roughly a 3 to 6 month clinical problem. We'll show you some of the titles in just a moment. Looking at that list, it looks like some pretty good training. We're pretty proud of that. If you look at the first asterisk there on your left-hand side, the 8 hours in diagnostic. If you're a therapy physicist, we think that you must have at least that many hours of diagnostic to be a practicing therapy physicist. On the right-hand side for the diagnostic track, you don't see that necessary for therapy. So we don't ask a diagnostic physicist to take all those courses in therapy. But there's a lot more electives. Yeah, because there's a lot more areas. So do you like CT? Do you like mammography? Do you like MRI? So we have a larger chance, more opportunities and more electives for those diagnostic, for those diagnostic students to participate. But on each side, it's 50 didactic hours and the 6-hour research problem. Now the electives, you have to be somewhat creative here. No way can our department support 50 hours of courses. We can't do it with our faculty, so we depend on other departments, other colleges providing those classes for our kids. And you can't always make the curriculum. So it doesn't fall the way you'd like to have it, such that I have an extra 3 hours for the spring, so I'm going to pick the best class option for elective. So we're sometimes caught in the bind of having to go with the university flow. So cancer biology, quantitative functional imaging, cancer imaging, etc. Statistics, ethics, healthcare delivery system, a new course that we found in nursing school just this year, and finance and economics. So some unusual, perhaps, electives. Research topics. So what does that 6-hour credit mean for a research project? Somewhere between 3 and 6 months full-time equivalent. Well, those are the projects we'll talk about on the next slide, but it should be a research topic, subject matter, have a mentor, you do a literature survey, you do some experiments, obviously, data analysis, you present it to your research curriculum committee, have a seminar, you have a final manuscript, in a format submittable to medical physics, to the Journal of ACMP. Didn't have to be published, but in that form. We encourage to do so. We encourage them to submit abstracts. But the requirement is to submit in that form so you know how to do that, and it could be something worthy of publication if your editor happens to think so. If your editor doesn't happen to think so, then it hasn't torpedoed your DMP program. Some examples of what that might mean at Vanderbilt. Energy response and dosimetry of OSLs for radium-192 HDR applications. 3D electron compensators for radiotherapy. Small field dosimetry. Ophthalmic brachytherapy, etc., etc. Those with an asterisk have either been presented at the APM summer meeting as a poster session or will be presented this summer. So our kids are at least making topics that can be submitted as abstracts to the APM and hopefully to this spring meeting next year. Okay, so we've talked about the didactics. Let's spend a few minutes talking about the clinical. All along, our philosophy has been, in the master's program, you've got to get some clinical in before they graduate. So that's still our philosophy. We're going to do didactics up front. We're going to have then 2 years, years 3 and 4, for the residency. But we think you need something in those first 2 years. But those first 2 years, you're not exceedingly savvy in the clinic, so sometimes just being there is not very good use of your time nor our time as mentors. So what we do is we try to incorporate 6 additional hours in the practicum, just as we do for all master's students. So interspersed beginning the first summer year, for example, in therapy, you will do brachytherapy, treatment planning, and quality assurance that first summer. In the second fall, you will do some LINAC QA. In the second spring, you will do treatment planning and additional QA for a total of, again, about 200 to 300 hours of clinical experience. Then when you enter July the 1st of your now beginning your 3rd academic year, you are up to speed, and now those additional 24 months, you're basically ready to go day 1. You've been in the clinic enough to know your way around, to be able to handle problems, and now your observation and your participation becomes much more clean, much more effective as you proceed into that first part of the 3rd year. So again, first 2 years are didactic plus 200 or 300 hours of practicum. The last 2 years will be full-time clinical rotations. Similarly for the diagnostic model, we've never had a diagnostic therapy resident. We have a first-year student approaching the 2nd year. So she will begin this summer her diagnostic practicum. So over the next 3 semesters, she will be getting up to speed, having been introduced to diagnostic radiology practice. Then in July of next year, she will be prepared to start her 2 years of rotations. So the topic was not about the program, but what have we learned about the program. So here's the things that we've learned. The timing of the curriculum is everything. Sometimes that's out of our control. So we're trying to get a little better feel for timing of the curriculum. We've got our courses well established, but we can't dictate to other colleges and other departments when and how they do their teaching. So we're working within their constraints to make those 50 hours work in the first 2 full years of our graduate program. Typically what's happening is they're lacking 1 or 2 of those didactic credits, so they fall into years 3 and 4. CAMPEP has said it's okay if a resident can take a class a year, so we're in line with that. So sometimes our students might be taking a didactic course for 1 3-hour credit each year. As I've already talked about the practicum, getting them up to speed, it's really nice to ramp them up and have them ready to go in that first month of their 24-month rotations. The research project begins in the summer of year 2 and could fall into the next 2 or 3 years, the next 1 to 2 years, depending on the completion of the project. So we think that's okay. They've spent probably a good 2 to 3 months in year 2, and then as they start their rotations, not every day can you have them doing something full-time, so it's nice to have a project that they can always be working on. So this has worked out rather well for us. We do have an advanced seminar topic and an advanced laboratory, which I think is more important in years 3 and 4, so we did not push that into the year 1 and 2 curriculum. Teaching and learning opportunities never cease. Now remember, I'm touting this as a 4-year program, not a 2+2. So you've got captive students now for 4 years. So we try to educate them for 4 years. So there's always patient conferences, tumor boards, medical ethics monthly conferences, webinars presented by equipment manufacturers, professional seminars Thursday. Let me tell you about that. It's on what is a professional, how to become a professional. Equipment manufacturers bring in the new products, regulatory issues, errors, misadministration topics, and ABR mock orals. So there's not a credit for this, so the kids come every noon on Thursday to participate in their better knowledge of being a medical physicist. You're not getting credit for it, you're doing it to become professionals. And that's one of the more exciting times for me as a leader, is to just see them there, glued in, sitting, understanding, absorbing what's going on. Doesn't matter the topic, they're young minds to be used, to be filled. And our students are now participating in year 4 in the teaching of our residents and the teaching of our RTT students. So they are getting, as CampEP suggests, some educational didactic experience in their own teaching and helping with the labs and recitation classes. Integration of didactic and training, it's a continuum. It's not 2 years and 2 years, it's 4 years. We do have the software that Mike Mills talked about, the Typhon software, to help us maintain and at least have documented what they've done. There's always fellow students, colleagues, friends are always available. Now there's steady state 20 of them being in years 1 to 4. So there's always a student in the next year's class. There's always a student in the class below. So the learning between classes is phenomenal. Slow times are always filled with ongoing projects or assignments. The awarding of the white lab coat, that's kind of a cool thing for us. That happens in the summer of the 2nd year. So you've been toiling now in the diagnostic 2-year cycle, and finally you're getting ready to do some clinical things on your own and become a medical physicist. Well, we present them with a lab coat with their name and medical physicist on it. It's a proud moment. So we're thrilled about the lab coat ceremony. DMP assistance is wonderful. I feel like a MasterCard commercial here as I go on. Okay, having their assistance is wonderful. Competence is assessed by their doing a plan correctly and it being checked by 2 physicists. So that doesn't happen the first rotation. It may not happen the second rotation, but as they gain experience, then how at Vanderbilt we grade competency is they've done the plan, and before it ever sees a patient, that plan has been checked and approved by 2 medical physicists. If that's the case, then you get to count that as a competency of success. DMP assistance in IMRT and Rapid Art QA is priceless. Okay, we don't have the staff to be able to do that for all of our IMRT QA as physicists. So we do use these young folks to help do that. We do try to make it equitable by offering them some small stipend for their process. So there's presently 7 of them now. 3 in the 4th year, 4 in the 3rd year, and those 7 folks take a week and they do our IMRT QA and our Rapid Art QA, and we give them a small stipend for doing that for us. Convincing administration that that's a clever idea, that that's a neat way to pay for the quality assurance is still a burden. I haven't got it successfully done yet, but I'm working on it. Other rotations, there is one rotation called Other, and that's an opportunity for you to go to radiology to learn some more diagnostic and to perhaps visit a community center where there's a different equipment or a different model for radiation oncology where they can learn from something other than an academic center. I've looked at that NRC AMP status for an HDR operator, and I want to tell you that in my interpretation, I would sign the paper. So when my 3 guys graduate this July, if they want to become HDR, NRC approved folks for HDR, I'll sign the paper. I'll let the NRC do the final paperwork, obviously, but I feel confident that they will be able to do that with the 2 years of didactic and the 2 years of on-the-job training, so I think that meets the spirit of the NRC requirements. We're learning that the growth potential for the diagnostic track as more and more legislation comes down the pike. I think that diagnostic is a very, very open field that many of our young students may choose to participate in. And every day I'm still convincing administration it's a clever idea. There has been some difficult learning lessons, and I'll talk about those now. Busy clinic must be balanced with proper mentoring. Mentoring is more time-consuming than thought. Than thought about, okay? Well, yeah, I can mentor, but saying I can mentor and being a mentor are 2 different things. The student-mentor ratio is important for CAMPEP, and certainly I will validate that. I am on the very, very bottom line of this correct student-mentor ratio, and I'm paying for that. So what I need to do is get more mentors. It is a difficult task to be a mentor. End of rotation evaluations is more work than I thought. It's okay for 1 or 2 residents, but now we have 7 every end of every rotation. So that creates a problem for us. Sometimes an observation and participation is still a toss-up call. We've got the competency, but participation and observation is still a toss-up. In all the busyness, there are still downtimes. There's time when there's nothing to do on my rotation. What am I going to do now? Well, am I going to read the book? Am I going to read the task group? So we're making other opportunities available. So we're probably going to give you a second. Being Charlie Coffey, if you know me, there must be a second something you can be doing. So if brachytherapy was your first rotation and there's no patients on that today, then you'll be serving a second rotation in IMRT. So trust me, we're working on that. Mentoring adds a busy workload to an already busy day. So you have staff, you have faculty who've already worked 8 hours a day, but you want them to work a couple more hours to do mentoring. That's a requirement. That's a problem for us. Making the finances work. I would love to have another mentor. I'd rather have another faculty person. That would be great. As I've alluded to, curriculum. It's tough always to get the very best elective appropriate for that student in the semester we need it. One department cannot offer 50 hours of didactic curriculum unless you're an awfully large department in an awfully large university. We're trying to get the word out for the diagnostic track. So, curriculum again. I want to better coordinate our intro and our advanced laboratories. As it goes, I'll have a introductory laboratory one semester. The next semester, I'll have an advanced laboratory. Well, they're similar concepts, but I teach 2 separate courses in 2 separate semesters. So if I could somehow piggyback one off the other, wouldn't that be clever? So we're working to try to make advanced, or to make the introductory and the advanced a little more contiguous and a little less time consuming on the mentors and the teachers. have the same mentor be able to do a number of students. So you've got 3 or 4 students there. Can one mentor do more than one student at a time? The answer is certainly we should be able to do that in a classroom environment. What's the future of the MS program at Vanderbilt? I think quite seriously it's this. Unless Vanderbilt can guarantee a residency, we will probably disband our MS program. Now, if I had some of you to step up and say, Charlie, I'll take a Vanderbilt MS graduate every year, hey, we're in. Okay, I have no problem with graduating an MS student who can have a guaranteed residency. But short of that, if I can't make a DMP slot, then probably we will not have a MS offering after 2013. Making the finances work, that's always a problem. Balancing tuition versus the needs versus students understanding, hey, are we going to ask a student to pay for 4 years of education? So we're trying to balance that with the tuition charges. The biggest thing we have to do is take control of the evaluation process. Admittedly, I'm not doing that very well as a mentor, so that's my number one goal this summer is to take control of that and get that shored up. Other DMP programs, I've heard from 3 individuals or about these 3 programs. The Texas Tech program was approved by the state of Texas Higher Education Council. I understand now that that program is now on hold academically within the university. I have talked with a gentleman from MD Anderson and from San Antonio UT Medical Centers, and both of them have works in progress. So they're talking about DMP programs. They're going through those faculty and that first level of approval within the university. Again, each state institution, as is the University of Texas, as did Texas Tech, will have to be approved by that Howard Council of Education in Texas. Final conclusions. A DMP program is more than 2 plus 2. If you leave here today with nothing else, that's what I want you to leave with. It's simply not a master's degree stuck onto a 24-month residency. If you do it in one continuum, it's much more than that. In our case, we can get in a lot more didactic hours. We think we have a better product than a master's plus a residency. No offense to anyone. Just if you have 4 years, you can do a better job with that, be more efficient. Commitment required for those folks who are thinking about it, for those programs thinking about it. Training and teaching is a culture. It is what we do. It's a team concept. If your therapy team, if your diagnostic team cannot buy into clinical service and teaching, you shouldn't be thinking about a DMP program. Okay? It encompasses everything we do. You've got to have an educational program that has sufficient clinical training resources in-house. Vanderbilt has a limited number of patients per day, about between 80 and 100 patients per day. We cannot have more than 4 residents in a year. So we have 4 DMP 4th years. We have 4 DMP 3 years. So I'm telling you, that hardly will go around an 80 to 100 patient per day facility. So you've got to have the clinical facilities able to support a DMP program, at least in this case of 4 students per year. DMP programs, as Mike has said, will result in fewer MS students being admitted. And particularly to the Vanderbilt program, we are seriously considering closing our program because we cannot guarantee them a defined residency or DMP slot. Now the positives, and I'll close with this. What we think the DMP program can do is give an edge to both students and to employers in this difficult day of healthcare reform. We give them, hopefully, more tools for the workplace. We give them at least a selection of the work environment. So they see academic practice, then go across the street, they see private practice. They can see a community setting. So now in that 4-year continuum, when I graduate, I think I would like to target A versus B versus C. It's an opportunity to negotiate professional status rather than staff status. I believe this is going to be attractive to employers. I don't want to be doom and gloom, but the day of increased salaries, the day of always upward mobility is coming to at least a saturation point. Employers may not be able to go to the well too many times and say, I need another salary increase for my staff physicist. I need another salary increase to keep up with the market flow. But if they have the opportunity to have a person in a professional slot, that may be better received. So we think, A, the student has a increased professional advantage in the workforce, and we believe the employers have an added advantage of having a professional in their staff so that they can do more and better things for them. And lastly, as I said, yes, it can be done. We're not perfect. I'm not saying we've got the model that you should go by. But I think we've proven the fact that a DMP program can be successful. It can graduate students. That being said, I have 3 students. I'll hear the first bid starting at 75. 75, 80, 85, 90, 95, 100, okay? Seriously, we're excited about the perspective. Students are coming now. We're recruiting students for the DMP program. And it's catching on. Students in undergraduate are hearing about the programs, and they're asking us about the DMP. So I'm excited to introduce this to you. Thanks very much.
Yeah, Charlie? Charlie.
Yes.
You mentioned that, no one department could do the 50 hours of didactic work. What's the number of your faculty that's actually contributing to the diagnostic courses or to the didactic courses right now? How many guys do you have teaching?
All right. We have 3 therapy physicists, 3 PhD therapy physicists. We have a radiation biologist. We have a health physicist and 4 diagnosticists. So that's a total of about 8 or 9 faculty who are in charge of the core curriculum. Okay. So that's going to cover about 30 of those hours. It's not going to pick up that other 20.
And how are you supplementing it? Then you mentioned a nursing course or something. And
those electives, we're going to DME, we're going to stats departments, we're going to math departments, we're going to ethics, in this case a nursing department, and letting our students sit on those courses. Yeah. So they are getting college credit for those courses. It's under my purview, so at least I get to vote no on an elective option. Okay, so currently that's the program director's option.
Charlie, well, first of all, congratulations on being a pioneer and getting this kind of program going. All of us owe you a great debt of gratitude. One point that you alluded to is not clear to me. You're charging these people tuition, fairly steep tuition. You're a private institution. But at the same time, you're saying you don't have the funding to bring on additional FTE faculty physicists to be clinical mentors. Where's the money going then?
As you travel north from Chattanooga, you will see the ground suddenly sinking. Okay, and there's a big sinkhole just about Nashville. Here's the reality of the matter. The School of Medicine has a very nice philosophy. And with the administration of the School of Medicine, their idea would be if we could give medical education free to all Vanderbilt graduates, that's what we would do. So I thought that's a pretty cool idea. So can I get part of that? So we have taken part of that action. Essentially, the Dean of the School of Medicine gives a fantastic scholarship to every student who enters our doors. So once you're accepted at Vanderbilt, you can get about a 70% tuition remission at Vanderbilt. Now, you take a rather expensive credit hour cost and multiply it by 30%, and it's very reasonable. So our students get a very reasonable rate. How has Vanderbilt instituted a master's and now a DMP program and get students to be able to pay the tuition? It's because of the dean's very willing, wonderful nature to allow a fantastic scholarship to our students. So on the positive side, I'm all for that. Now, your question is directly germane to the other side. If the dean is not getting the money, is he sharing any of his money? The answer is no. So basically, we have no dollars in our clinical departments to run a program. So we're doing it as bare bones as absolutely possible. So the answer is yes. If we shift the burden to the students in tuition, hopefully the dean will reimburse that money for us in salaries or for another salary line. That's not a guarantee, but in the future, I'm going to have to go that well. So we've been fortunate in that we've had a program, we've sustained the program, and the students have paid a small tuition cost. In the future, that will change. And as other DMP programs come online, there's going to be probably an average value of tuition. Vanderbilt will start charging out average tuition, and hopefully we can convince the dean that he will reimburse our faculty for the top of life. So right now the answer is our students get a nice deal. The difficult side is that our own chairman supports our education program. He allows us.
First of all, I really appreciate you guys did all this work, make it, I can see the future of the profession because of your responsible program director, because I already see there's other programs, they just produce this 20 master students out there and they cannot find. I'm from University of Utah, and then just at a smaller place in Salt Lake, there's 2 master level students over summer will work with us, volunteer. They contact us just proactively, and then we have to take them even they are not paid, but at least we can offer them some kind of a project to do the work. At the same time, I feel sorry for those students when they get into the program. I don't know how many people tell them about the job market and stuff. So I really, in that regard, respect all your work for this field. And I have a couple of comments. You mentioned this faculty and the student ratio thing, and also it's hard to mentor students. So have you considered about after the 3rd or 4th year, send some of your students to satellite, and then so some others can share the burden?
You're a very great young man. So yes, come right up here, you'll be on the faculty. The answer is absolutely. So if I could select in Nashville 2 or 3 community satellites, would you please allow my students to be a residency at your site? Be it, what's minimum? 2 to 3 months is minimum. Okay. The answer to the question is, yes, that's a great idea. That's a good solution for me. But there is now the administrators have to talk. We can't send a student across the street because of viability. There have to be dollars and contracts. So we're relatively new at this. So yes, exactly what you say. The only way Vanderbilt can A, reduce our pressure, and 2, take any more students is we'll have to have cooperating residency satellites, if you would, to help mentor our students. Absolutely.
And also the other thing would be the student will see variety of practice.
The concept I said of the other rotation, that's exactly what we have in mind. And I would be delighted if 10 of you came up afterwards and said, Charlie, I'll take a student for 3 months. Okay?
Second comment is, do you have in your curriculum any class or any training for communications, verbal or written communications? Because, as a physicist working in the hospital, I see that's a very important factor. Not
specifically. Indirectly, I would answer that in 2 ways. our students are incorporated in the therapy clinic from the beginning of the second or the first summer they're there. So they're beginning to interact with physicians and the physics staff. So yes, that's for about a 2.5-year project. Then number 3 on that professional Thursday, they go to the board and answer questions in front of their peers and in front of me to be able to communicate answers to quality assurance problems or some theoretical concepts. So the answer is we practice that. We do not have a didactic class.
Lastly, the quick question is, I really wish your graduates can all find a job. Basically, that's how can support this model and then for a successful model. Just a curiosity, what's your first year graduates? Are they, how's their luck right now?
Okay. The 3 gentlemen they've been in the resume writing mode now since about January. Just within the last week or 2, they're getting some nibbles. They're getting a couple of interviews via phone. So it appears the present thing is I'm not going to invite you out to my facility yet until I interview over the phone. So they are getting phone interviews. So I talked to a gentleman yesterday. He said, Dr. Coffey, I had a really delightful interview on Friday. It went very well, and I feel for the job they wanted, which was a 2-year experienced physicist, I feel for the job that they wanted, myself and the other 2 graduates will certainly meet their needs. So he was confident that he's going to be okay in a job like that.
Dr. Coffey.
Someone ask Mike a question, please.
Sorry, I won't be the first, but you mentioned the uncertainty surrounding your master's program, but can you comment on the effect that the DMP program has had on your residency? Do you continue to accept to residents in addition to the DMP program?
Good question. I failed to mention that our residency stopped about 2 years ago. So those dollars that I had in the residency slot, I elected to spend those dollars, clinical dollars, in giving a stipend for years 3 and 4. So no, I do not have a residency.
Thank you.
I guess I was wondering, I guess for either of you, I've heard rumors of a match being involved in upcoming for the residencies. And so I was wondering your comments on that, and then possibly how does the DMP fit into that, since it seems like it's a fixed residency spot for the trainees.
I can answer a little bit of that. We do have unofficial cooperation for a match. It's a project that's actually being driven by someone in this room that may want to speak to that, John Adelack. And I think it's moderately successful. It has some flaws because some of the Canadian programs are not on the same time sequence. Some of our programs here in the U.S. do not follow exactly the same time sequence. And some of the program directors are not completely on board with this, or if they say they're on board, are not completely honorable in holding to their commitments and make offers early. So, John, did you have anything that you wanted to say? No, not really. Okay.
I think the DMP answer to that is for a limited number of DMP programs, I would not think a DMP match would be appropriate this time. So I would think that if you have a DMP program, if you're recruiting students into your graduate program in year 1, that you would have the right to select that student, and there would be no match in years 3 and 4. So it's a 4-year commitment. It's not a 2+2 commitment. So I don't see presently a quote match in the DMP as long as there's going to be 10 or 15 players before that would ever be possible.
Thank you. I think I would like to ask the question to both the distinguished speakers. The question is there any channel open for international students, meaning students from outside United States? Is there anybody you will take who can apply to you or somewhere to get into this field and get trained? Because most of the international most of the other countries are gearing up in cancer therapy, and likewise in the United States. So I would like to know for sure whether there is a channel open to them to be in this field. Thank you.
Yeah, I'd like to comment on that. First of all, I look at every application that meets the university's requirements. The University of Louisville requires the students to have or to possess either citizenship or a green card. If you possess citizenship or a green card, then I will look at your application. Now, I have a standalone residency program, which means that I have limited resources to have people go back and do any remedial work. There's no medical physics program on campus academic. So I have preference for people that graduate from CAMPET programs. The CAMPET programs, academic, are all within the United States and Canada. I look at folks from the United States and Canada equally, and I try to look at folks that have masters and PhDs relatively equally. And what I look at most are letters of recommendation and secondarily grades and other attributes in the academic record. The short answer to the question is yes, but it's very difficult to be competitive in the current environment unless you come from a CAMPET program for those residency programs that are standalone.
My answer to that question would be similar. You must have the academic credentials to do that. So if your university internationally has the same standards as we do and you meet the requirements, then yes, I would consider your application. There is one small caveat. From the very beginning, about 2 or 3 years ago, we had an incident where we took a student and we hadn't met that student. It wasn't a very good fit. So we have the following rule in place. You, as a student applicant, must visit the university on an invited trip by us. We can't pay for it, but we ask you to come to campus. We'll host you. We'll provide for you a day's activity, getting to know you such that you would think that we want you, you would want us. So for our international students, that becomes a burden. So that is one caveat that is a difficulty for international students, the requirement of being on campus at least for 1 day.
Charlie, that is a wonderful program. It almost inspires me to want to come to your university and go through it all again. Not really, but all the things that we senior people have learned over the years. I know it's difficult to try and put it into 3 or 4 years. But there is a couple aspects of what you've done there, or what you have in there, is where that I really like, is that you review the task groups of AAPM. There are many of them, and I really like the idea of your seminars where you look at the misadministrations that we have gone through, because too often we learn what we're supposed to be doing, but we don't look at what could go wrong. It's sort of what if this happened? What would you do? Kind of a thing. And I don't know how many of the residency programs today do that, but I like that idea.
Someone is coming up with an errors analysis class, and I proposed to Bill Hindy, wouldn't that be something cool if the AAPM could get a qualified speaker bureau and do a course so that every program could get onto that course and have an errors analysis, certainly one of which would be treated in this version. So that would be a goal for mine for the AAPM and ACP in the future to have that continuing in.
So my question's from Mike. A lot of your conclusions really resonated with me, and two things stuck out. One, the statement that if a master's program can't guarantee your residency, then you should lose your accreditation. It's a very powerful statement. And the other thing was you were saying that you're trying to get this message out, and so I was wondering what avenues you were using. Like, for example, I know that there is a Society of Program Directors for Medical Physics. So have you met with them, and what is their feeling, and how, what's their take on the issue?
Haven't met with them. In fact, the first rollout and test of this on a national level is this meeting. I want to gauge the response, and I want to understand the culture and understand what the response of the community might be. Clearly, the SDAMP needs to be involved, and they need to help come up with a consensus recommendation to AAPM leadership. Clearly, the councils need to be involved. The administrative, education, and professional councils all need to consider these kinds of perspectives. Between all of this, maybe we'll see sometime this summer, sometime this fall, something of this nature will come together, and we'll have a unified recommendation for CAMPAP that is a consensus built by all of the stakeholders. And I'm hoping to be a very little as part of that process. I'm not in the leadership role in AAPM, in CAMPAP, or in SDAP. I'm a committee chair, and I'm hoping to cause enough trouble and to provide enough information that the profession will respond appropriately.
Hi, I'm going to take up your challenge, Mike, and you threw up some very provocative comments on your slides. I wonder if...
I would hope no less.
If the master's programs disappear, okay, let's say that your future comes out, master's programs disappear, then...
No, not that they disappear, that they not be accredited. I think there'll still be master's programs.
Well, then where are they going to go? Where are those graduates going to go? If we're going to train people in medical physics and give them a master's degree in medical physics, that's a disservice. But I agree we need residencies for them. But I think that the type of program that Charlie's put together, it's a wonderful program, but that's beyond the means of what most people can do. You look at a lot of small residency programs, they can't put together a professional doctorate. They can't do that sort of thing. So they're going to go out of existence. You're going to drive small residency programs out of existence.
No, we still accredit the residencies, even the small residency
programs.
But
these residencies go for master's graduates. Many of them do. So those small residencies that want master's students, the small number that do, okay, they're not going to be able to find students because all of those students will be in the professional doctorate. There won't be anybody because if you don't have a CAMPEP master's degree, they're not qualified to get into that residency. So there's a double-edged sword there. I don't know if you need to get rid of the master's programs completely in order to make the DMP meaningful. I see the DMP being more as it's accredited by CAMPEP as a graduate program. It's accredited by CAMPEP as a residency program, and I think that's the appropriate thing. I would hate to think that CAMPEP has to put together yet another committee that's going to evaluate DMP programs as well, and then somehow have a dichotomy between how residency programs get evaluated versus how DMP programs get evaluated because it's done by two different committees. Right now, as a member of the Residency Program Review Committee, and you see the same thing, when you see the reviews come back, there's a dichotomy in how residency programs are reviewed. Some residency programs, depending on which reviewer goes out to that site, they get reviewed much differently than other programs do. They get held to different standards. I don't know if as a residency review committee we can even all agree on what those standards are, and I think we need to work on that as a first priority rather than trying to change the entire model by which we educate medical physics residents. The other thing that we need to keep in mind as well is we're probably, if we go to this type of model, we're going to lose the diversity of backgrounds that we have right now in the field. We're trying to create alternative pathways. Those people that don't find out about the profession until they're already well past their master's or PhD degrees, and then they find out that, oh, gee, I was thinking about being a doctor, but I really loved physics, and so I got my physics degree and I got my PhD, and now I'm looking for something to do, and oh, they have physicists working in a hospital? So what are you going to tell them, that they now have to go back and do a 4-year professional degree and not present some sort of alternative pathway? There's a danger that you may supply all the demand with the professional doctorate if that becomes the smooth pathway, and then that alternative pathway is going to dry up.
Yeah, let me answer several of the points. I hope I can remember most of them. One is that I don't expect the residency programs to dry up. What I expect to happen is the residency programs to enter into agreements with DMP-type programs. And remember, it's only CAMPEP that calls them the DMP program. They could still exist as master's programs. They just have to provide an appropriate number, whatever that number is, of residency slots available. So maybe what will happen, and I'm speculating, is University of Kentucky will come to me and say, hey, we've got to get a couple of residencies on board. Are you on board with us? And I'd say, okay, let's look at this, and maybe I get my choice of one of your top 2 students, and we can talk about that. And so that's what I expect to happen. Do I expect all residencies to do that? The answer is probably not. I suspect that some of the residencies that are standalone will still accept the kind of students that you're talking about, those that have doctorates in particle physics or solid state physics, and want to get into medical physics. There will be still a few residency programs that will accept those folks that will provide for this kind of diversity. So I don't expect all residency programs to sign up. Now, in terms of the CAMPEP model, yes, CAMPEP would really have to step up, and they would have to cross-train the folks that are doing academic and residency evaluation, such that people like me would have to do an academic evaluation, and people that are doing academic evaluations would have to become knowledgeable in doing residency evaluations in order to come in and evaluate. A single program would say 6 MS physics slots per year and 2 residency slots per year, and do that in a single site visit. But I think that we need to think about, if this model works, for stepping up to the challenge. Regardless, we have got to get a handle on putting too many MS medical physicists into the community that can't get jobs. And this is one way to do it.
I notice we're at the end of our time slot, so we'll take the last 3 people who have got a spot in line, and then that's the end. Let's say that's the end of the line.
We are still going to need medical physics residency programs for all those people who have, first of all, received PhD degrees from CAMPEP accredited medical physics programs, and in addition, those individuals who are entering medical physics via alternative pathways, as John has indicated. All they will need to do is satisfy the didactic requirements of AAPM Report 197S, and then they would be eligible for a CAMPEP accredited residency program.
Yeah, and I was going to make the same thing. I mean, alternative pathways fine, but you still have to have those major didactic courses in order to go into residency programs. Because, I expect the people we have applying for our residency programs to have that academic foundation because they hit the ground running when they hit the clinics. But on the thing, Charlie, too, on the possibility of also sort of contracting with another with a residency program, the one thing I do see on that one that would get your opinion on, well, how does that residency program have any input as to which resident they get. So it's almost like, here's my blank check, Charlie. You know,
the two-pronged problem. Obviously, Charlie Coffey's going to keep the brightest four.
Obviously.
You get the lesser help. Obviously, that's not integrity, so that's not a good solution.
So
it would be an issue, yes. A workaround would be if instead of being a full residency, let's say you elected to have a 4-month or a 6-month rotation, and you took either 2 or 3 kids. Now, all of my kids could go to your facility, et cetera. Okay, so that would make it so that not the best went or the best stayed. Okay, so the absolute thing is, yes, you have to be a part of the didactic ability of that student. You have to know what you're getting. So you would have to share that with you.
There's a question for Mike. I mean, originally, as I understood it, there were, CAMPEP-approved master's programs and CAMPEP-approved residencies. And the idea was that the CAMPEP-approved residencies, there would be some that would be glad to take people who had graduated from CAMPEP-approved master's programs. So obviously, from the graphs that you showed, this is not happening. Why do you think this is? Do you think there are just a need for more small CAMPEP-approved residencies? Or do you think that there's some inherent problem in the system where even the small residencies are preferring to take people who have doctorates?
I think that we have several things going on. One is that a lot of the large academic programs graduate master's level and PhD level folks. And for the residency slots that exist, the PhD level folks have an advantage to compete for those in-house slots. Secondly, I think that all of the Canadian slots are completely off the table. The Canadians graduate all of their own in-house folks and move into their in-house residency slots, so no one can compete for any of the Canadian slots. Thirdly, all of the smaller residencies, such as University of Louisville, that don't have an academic program associated with it, there is a tendency to prefer the PhD students. Although I try to be very fair, and I try to, as much as humanly possible, disregard the contribution of the PhD versus the contribution of the master's. The process that we use for resident selection evaluation is spread out over 8 different individuals. And by the end of the day, after we have gone through 100 applications and we have 5 finalists, 4 of those will typically be CAMPEP PhDs on top of CAMPEP Masters, and 1 of them will be a CAMPEP Masters. And by the end of our interview process, our first, second, and third alternate in our selection will often be a PhD. And that's the process. No one controls that process, it just is. Multiply my experience in institution by 15 to 20 or so of the smaller residencies that have no academic program associated with them, and considering the fact that we still have about 50 PhDs or so seeking to get into CAMPEP residencies, then the PhDs are more successful, partly because they have broader and more extensive clinical experience and thus are preferred. In addition, we don't generally have to worry about the fact that they might or might not qualify to take the ABR exam. That's a worry that we don't like to have, and if we have half a dozen to a dozen CAMPEP PhDs applying, you would do the same if you were in our position. That's the reality that underlies the slides that I showed.
This is an important dialogue with you